Hello everyone, in this video we're going to be talking about EKGs. My name is Bryce Pugh. I'm in the class of 2027 at the Brody School of Medicine. And the plans for this video is to go through the basics of EKG very quickly, how to read an EKG on clinical rotations, and then rapid fire examples that should be helpful for step 1 or medicine shelf exams and stuff like that. So I'm not going to spend too much time going through the basics just because this is more focused on these two. But I will talk a little bit about it. So let's go through the basics first. In EKG, you're typically going to be looking at a 12-lead EKG, and what that means is you place these 12 leads on a person, and it's going to detect the electrical signals of the heart. And you place them in all these strategic locations so that you can see which direction the signal is passing. And so if you think about how the heart sits in the chest, it's kind of sitting at this angle here. And so you'll have the detector from the signal that is coming that way. And you'll have each of these that you can see here, V1, V2, V3, V4, V5, C6, and then you can calculate lead 1, 2, and 3 based on right arm, right leg, left leg. And so these are just quickly how you get those if you're curious. Lead 1 is left arm minus right arm, and so that's going to be this signal here. Lead 2, you can see, is going to be here, and lead 3 is going to be here. And so here's the output that you're going to get with that. And the way you look at this is it's going to tell you which lead you have here in the corner here, which lead, and then it gives you the rhythm strip from that lead, and you'll get this distance. And so from here to here is lead 1. And so you have lead 1, 2, 3, AV, R, L, F, and then V1 through 6. At the bottom, they'll usually put a rhythm strip, which typically it'll be lead 2, but sometimes it'll be more than one or a different one. And that's just to give you a longer reading of one strip if you need more than just here. So if you see this only gives you like 3 QRS complexes, here you have a much longer strip that can be helpful for analysis. And so these are your 12 leads up top, and then you have a long rhythm strip down here. When looking at the EKG, I want you guys to generally keep this in mind. You don't have to super in-depth analyze it, but this is the output. You have bump, spike, bump. And what that represents is your P, Q, R, S, T complex. And so generally, the P wave is going to be atrial depolarization, and the atrium repolarized, but it gets hidden under the QRS complex. So you have atrial depolarization, and then you have ventricular depolarization, which is the big QRS spike, and then you have ventricular repolarization, which is your T wave here. And so you can see you have intervals, like the PR interval is the delay between the SA node firing and the AV node transmitting it to the QRS complex to the ventricles. And so you can pause the video and look at this if you like, but these are going to be the different intervals you look at, PR interval, QT, and stuff like that. We'll come back to it a little more. And you'll also notice that the EKG is written on this grid paper. And so you're going to have small boxes and large boxes. Each small box is 1 millimeter. And so a large box is 5 millimeters, and each small box is 0.04 seconds, which is equivalent to 40 milliseconds. And so a large box is 200 milliseconds. And this will come in handy when you're trying to measure length of intervals. For example, the PR interval should be 0.12 to 0.2 seconds. So that should be, seconds. And so what that means is that's 3 small boxes to 5 small boxes. And so if your PR interval is bigger than one large box, that's bigger than 0.2 seconds or 200 milliseconds. And so that's a prolonged PR interval. And so you can pause and look at this if you'd like. I'm going to move on. And so here's your 12 lead EKG. Another thing that you want to be considering when you look at this is what location of the heart is generally being referred to when you have the different leads. And so like we saw here, the leads are going to be analyzing different spots of the heart. And so when you have this, if you have an infarction, a myocardial infarction, or a heart attack in certain leads, then you can localize which artery is occluded. And so generally, this is going to be a good example of how it's broken down. You have your inferior leads, which is 2, 3 AVF, your anterior/septal leads, which is V1 to 4, and then you have lateral leads, which is 1 AVL and V5 and V6. The way I like to remember this is the AV one kind of gives it away for me. So you have AVL for lateral or left lateral, And then you have AVF, I think of floor, so inferior. And then you have your anterior septal. I just think of like the V, V1, V2, V3, V4. All of that is your anterior septal. And then that kind of starts to transition into lateral. So you can't have like an anterior lateral complex. And so when you're thinking about that, if you think about how the heart sits in the chest, it's going to be laying kind of flat. And so you have your three main arteries that we're going to be thinking about here. You have your right coronary artery, which runs posteriorly and becomes the posterior descending artery. And it's typically like that in a right dominant heart. Sometimes a left dominant heart can make it a little different. And then you have off of your left coronary artery, the two main branches we're going to look at are your left anterior descending artery, which runs down the anterior surface of it. And so your right coronary artery ends up going to the posterior or inferior surface because the heart is kind of sitting on the bottom of it. And then off of the left coronary artery, you also have the left circumflex artery, which is going to run around the lateral side of the heart. So when you think of these leads, if you see indications for an infarction in your inferior leads, that's going to be a good indication that you likely have a right coronary artery infarction. It could also be left circumflex because some people have a left dominant heart, so it can get a little tricky, but generally for the purposes of step one and exams like that, when you see inferior, you want to think of your right coronary artery. When you see infarction in your anterior or anterior septal leads, you want to be thinking of your left anterior descending, the LAD. And then when you see infarction of the lateral leads, that's going to make you want to think about your left circumflex artery. And so that's generally how you want to think of it. This is particularly important for infarctions. And so let's quickly go through how to read an EKG. So this is going to be particularly important when you're on clinical rotations and you're having to read a lot of EKGs, but this is also going to be important for examinations like step 1, step 2, and the different shelf exams. So when you're looking through an EKG, you want to go through the same process every time so that you don't miss anything. This is a good process to go through that's going to cover everything. You should look at the rate, the rhythm, the axis, the intervals, the voltage, and the ST segment changes. And you should do it in the same order every time. And so this is a general overview slide. We're going to go through individually what each one means, and then I'll pull the review slide back up. Let's look at a normal EKG and go through each of these. So this is a normal EKG. First, let's look at the rate. How do you calculate the rate? That's how many beats per minute the heart is making. So typically, you want to look at the rhythm strip down at the bottom, which is typically lead 2. And so you want to count how many QRS complexes there are and multiply it by 6. So here we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 times 6 would be 72. So this heart rate is around 72. If you need to calculate it for a different way, for example, if you don't have a rhythm strip, you just have this small segment, then you can do it one of these two ways. You can count the distance between the R to R interval, and if you count how many big squares there are, you can do 300 divided by that. So if we have like 1, 2, 3, 4, just over 4 big squares, you can do 300 divided by like 4.2 because it's 1 square, and that'll give you about the same. That's a little less accurate, but you could also do 1500 divided by however many small squares there are. That'll be a little more accurate, but still the general way that you want to do it is QRS complexes of the rhythm strip times 6. That's how you should do it. Rhythm. When you're looking at rhythm, you want to first determine, is this a regular rhythm, like a sinus rhythm, meaning is it coming from the SA node? And the way you want to do that is you need to determine, is there a P wave before every QRS complex? So is the P wave, the SA node, sending signal to the ventricles to contract? And then you also need to make sure that it is coming from the SA node and not from some different location. And so first you can check, is there a P wave before every QRS? So I see P QRS, P QRS, P QRS, and I don't see any other P waves, and I don't see any other QRS complexes. And so check. And then you say, is the direction of the lead in the right, or is the direction of the signal in the right direction? So if we go back to here, if you have your SA node up in your right atrium, and it's traveling largely in this direction towards the tip of your ventricles. So it should be traveling in this direction, meaning in the direction of lead 2 for the most part, and in the opposite direction of AVR. And so if we come back to here, because it's traveling in the direction of lead 2, then it's going to be positive, meaning in the upward direction for that lead. And so it should be positive in lead 1, 2, 3, and most of those AVF. And so it should be positive in those, and then it should be reciprocal inverted in AVR. Because if you think about it, AVR is going to the right, to your right arm. That's the opposite direction. So the signal is going to be negative. And so that tells me that this is sinus rhythm. Some other rhythms that you're going to want to look at, we'll go through later. You can have atrial fibrillation, atrial flutter. And so that's when you're describing this for rhythm, you can say irregularly irregular, for example, for atrial fibrillation. The next thing that you want to look at is the axis. What the axis is telling you is the direction of the electrical signal. Is it moving from the SA node in the right atrium towards the tip of the ventricles? And so normally it's going to be in this region. The direction of the signal should go about from here to here, and it can vary a little bit. You can have axis deviation where the overall signal is going to be going more here towards the right or up here towards the left. Or in some cases, it can be going more towards this direction, which would be extreme axis deviation. And so to identify this, you want to look at leads 1 and lead AVF. And so you're going to look at the direction of the QRS complex. Is it positive or negative? And so we're going to look at examples in a little bit, but because both of them are positive here, I can tell that this is normal axis. And I'll explain the different axis deviations when we get to the examples. But so you want to look at those two signals to tell if it's axis deviation. And so here's some more slides to explain it. So you can have a positive signal, which is primarily going upward. You can have a negative signal, which is primarily going downward, or you can have an equiphasic signal, which is about the same going upward and downward. And so here's what I'm saying, where the direction of the signal from the heart is generally going to go towards here. You can have left or superior axis deviation or right axis deviation. And the way that you're going to tell that is by looking at leads 1 and lead AVF, and you can use this thumb rule, which a lot of people will refer to. And so you can use lead 1 as your left hand, lead AVF as your right hand. And you can hold your hands up if you need to, but if they're both positive, you get 2 thumbs up. That's a normal axis. If you have lead 1 positive, lead AVF negative, that's going to be left axis deviation. And you can think the hands left each other, and your right hand goes down to the floor, your left hand goes up. If you have lead 1 going down, negative, and AVF going up, your thumbs are going to be pointing at each other. That's going to be right axis deviation. And then finally, if you have both of them in a negative direction, both thumbs are pointed down, that's bad. You have extreme axis deviation, which is going to be pointing up here. And we'll look at examples later. The next thing you want to look at on an EKG is the intervals. And so the main intervals that you need to check here are your PR interval, your QRS, and your QT. So for your PR interval, that's the distance of the beginning of your P wave to the beginning of your R wave. And so you can see here, it's not too long. And I'll quickly go back to here. You can see our PR interval, the beginning of the P wave into the beginning of our QRS complex and the R wave. And so, like I was saying a second ago, you want it to be less than 5 millimeters, which is 200 milliseconds, so less than 1 large box. If the distance between your P wave and the QRS is greater than 1 large box, you have PR interval prolongation, and that can be very important. So you need to check that. Then you need to check your QRS complex interval, and so that's, you can probably zoom in here, but you can see this is about 2 boxes maybe, so that's 40, that's about 80 milliseconds, and so that's less than 120. If it's greater than 3 small boxes, 3 millimeters, or 120 milliseconds, that's going to be prolongation of the QRS interval. Finally, you want to look at the QT interval, which is going to be the Q to your T wave. And so the distance that should be around 330 to 440 milliseconds. That's about 8 to 11 small boxes. We'll talk about this in a second. The quick way that you can probably do this on clinical rotations or on rounds The quick way you can do is just look at your RR interval, and your T wave should be less than half of that. So if we look at our R to R, about halfway is going to be here. We bring that down, our T wave right here is before that. And so that's probably okay. And that's generally how you need to do it. If you have complex cases where this could be altered, then you might need to actually calculate it. Because QT prolongation can become pretty severe, as we'll see in a little bit. But one area where that might get challenging is if you have an altered heart rate. So if you're incredibly tachycardic, you might not have that long of an interval between your R and R. And so what you need to do is correct for the heart rate, and that's called your QTC, QT corrected. The way you calculate that, there's several different algorithms that you can look up. The primary one that we're going to talk about here is your QT interval distance, like up here, your QT divided by the square root of the distance from R to R. And so generally on exams, they'll probably give you a heart rate of 60 beats per minute. The good thing about that, the square root of the distance from R to R ends up being 1. So then the QTC is the same thing as the QT interval. And then if it's slightly below or slightly above, then you can figure generally what it'll be, or you can calculate it. And a normal QTC is going to be less than 450 in males and less than 460 in females. So the next thing that you want to look at on an EKG is the voltage. The voltage is generally telling you whether or not you have left ventricular hypertrophy, which is indicated by high voltage. The way you can tell if you have high voltage is generally how big the spikes are in these two, and so there's multiple different ways you can calculate it. This first bullet point is the way that I would recommend. What you do is you take the R wave in V5 or 6, so we'll say V5. I would look at V5 and V2. So we'll take our R wave, which is this spike, and our S wave in V2, which is this spike, and the summation of them should be less than 35. If it's greater than, then that's going to be left ventricular hypertrophy, which is high voltage. And so let's add it up. So big box is 5, 5, 10, 15, about 21 maybe. And then we have 5, 10, 15, 16, 17, 18. So 18 plus 21, that's 39. And so that's greater than 35. So this person, this might not actually be fully normal. This person might have some left ventricular hypertrophy. The next thing you need to check is ST segments. This is typically indicative of myocardial infarction or heart attack because you can have ST segment elevation. That is not required, but you'll see that a lot. And so there's some other things that can cause it as well, but generally what you want to look for is ST segment changes. Let me pull up the ST interval. So here's your ST segment from the S to the beginning of the T wave. And so interval includes the wave, segment does not include the wave. So let's go back to our ST segment. If you have a greater than 1 millimeter change up or down, then that's going to be change of your ST segment. And so you can look here. Here's our signal before our QRS complex. Here's our signal at it. So it's not changed by more than 1 box. And you need to check every lead for it too. Look down here, it's about the same. Look over here, it's about the same. And generally you can say, let's look at the inferior leads. Let's look at the lateral leads. Let's look at the anterior septal leads. And we don't see any ST segment changes. The next thing you need to figure out is it localized to the inferior leads or one group of leads, or is it diffuse across all or most leads? Because that's different things. And then, like we'll talk about later with myocardial infarctions, you can also have reciprocal changes. So you can have ST elevations in some area and ST depressions in one area. So you just want to look for greater than 1 millimeter of change up or down from the baseline. And so here, once again, is the summary slide of how to read an EKG. You want to look at rate, rhythm, axis, intervals, voltage, and ST segments. So go through this with every EKG that you see, and it's going to become second nature, and you'll start to be able to identify everything. So now let's move on to EKG Rapid Fire. The way this is going to work is I'm going to pull up an EKG, wait a second, and then I'll pull up the answer and give you a quick explanation. So if you want to try this on your own, pause the video once the EKG comes up and see if you can figure it out, and then see if you have the same thing as me. And so some of these are in order, some are in different order, so let's just get started. Take a second and we'll look at this one. 3, 2, 1. This is going to be just a normal EKG with a normal axis. And so I'm just trying to show this one to say this is a normal axis. Lead 1 and AVF are both pointing up, so no axis deviation. And then this is just sinus rhythm. This is the one that we were looking at a second ago, if you remember. Take a second to look at this one. 3, 2, 1. This is an example of left axis deviation. So you can see lead 1, QRS is positive, AVF, it's negative. So our hands left each other, the thumbs are in opposite directions, we have left axis deviation. And what does axis deviation indicate? It indicates if it's left axis deviation, then that's most likely a left anterior fascicular block. If you have right axis deviation, then that's likely a left posterior fascicular block. And so let's move on to the next one. 3, 2, 1. Right axis deviation. So you probably could have guessed from the previous ones, but we have our lead 1, QRS is negative, AVF, QRS is positive, and so our thumbs are pointing together. That's going to be right axis deviation. And everything else is normal on this. Take a look at this one. 3, 2, 1. This will be an example of extreme axis deviation. And so you can see here, this is pointing down, AVF pointing down. So both thumbs down, very bad, extreme axis deviation. Here's a reminder, you can pause and look through this or rewind if you want. Now take a second and look at this one. 3, 2, 1. This is an example of sinus bradycardia. So we talked about telling if it's sinus rhythm, we have a P before every QRS. We have our P is positive and leads 1, 2, the inferior leads, 1, 2, and then it's inverted in AVR here. And so it's sinus rhythm, but bradycardia. So what's the rate? 1, 2, 3, 4, 5, 6, 7. 6 times 7 is 42. Below 60 is bradycardia, so this is just sinus bradycardia. And here's an example of you have your 12 leads, and then they put 3 rhythm strips here. And so pay attention to what leads you're actually looking at. Next with this one, 3, 2, 1. This is sinus tachycardia. So the same explanation before to determine that it's sinus rhythm. Rate, we check it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. And so if we take our rhythm or our rate, we do 19 times 6, and that's 114. So greater than 100 is going to be tachycardic. So sinus rhythm with tachycardia, sinus tachycardia. 3, 2, 1. This is an example of atrial fibrillation. You'll hear atrial fibrillation described as an irregularly irregular rhythm. And what that means, you can see our QRS complexes, the distance between our RR intervals is irregularly irregular. So we have a short distance here, a long distance here, an even longer one here, shorter, short, long, short. And then we try to look at, do we have any P waves? I don't see any P waves. And kind of our baseline is just this squiggly pattern. So on exams, sometimes they'll do it even more obvious, like squiggly like this, but you have no discernible P waves, and your ventricles are just having to fire on their own randomly. They're not controlled by the SA node. And so atrial fibrillation, you have just random squiggles on your baseline, and then you have these irregularly irregular intervals between your QRS complexes. So that's atrial fibrillation. Next with this one, 3, 2, 1. I'm trying to trick you with some of these, but I want you to see everything. So this is also atrial fibrillation, but we need to further classify it, because if you did the rate first, you'll notice that we're tachycardic. And so this is determined as atrial fibrillation with rapid ventricular response. So when you have AFib, your ventricles are having to spontaneously contract randomly on their own. And so what can happen is you can have normal rhythm, a normal rate, 60 to 100, or you can have a rapid ventricular response where you have AFib with tachycardia. And that can come in at like 150 or higher. But when you have AFib, you need to determine, are they more stable with a normal rate, or are they tachycardic or bradycardic? So take a guess what this one is. 3, 2, 1. This is AFib with a slow ventricular response. And so same description as before, this is atrial fibrillation, but if you calculate the rate here, we're bradycardic, less than 100. Take a look at this one. 3, 2, 1. This is atrial flutter. And so atrial flutter is commonly described as a sawtooth pattern because you can look at the rhythm strip in lead 2 here. You have this, looks like the teeth of a saw, where it's just this spike, 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 spike. And so I have this described as a 4-to-1 conduction because that's how many spikes, how many flutters are happening between each QRS complex. So it can be a little to calculate, a little hard to identify, but maybe like 1, 2, or 1, 2, 3, 4 here. And so look for the sawtooth pattern with that. And so that's a 4-to-1 conduction of A flutter. How about this one? 3, 2, 1. This is atrial flutter with a 2-to-1 connection. So this is the same thing we saw before, but we're having 2 spikes between each QRS complex. So you still have this sawtooth pattern that you can see here, but there's only 2 between each one. So these we're looking at the same thing, just more sawtooths between. All right, take a look at this. 3, 2, 1. This is going to be an example of multifocal atrial tachycardia. And let's think about this name for a second, because it looks like a lot, but it's not as bad as it sounds. Multifocal, so coming from multiple different places of the atrium, causing tachycardia. So our heart is beating fast because we're having atrial signals from different foci or different locations. And so what would that look like? Well, if we're having signals from different locations, they're going to be different intensities. And so you're going to have 3 or more different P waves and tachycardia. So you can calculate the rate here. We're tachycardic. And then if you look at the P waves before it, this one looks different than this one, looks different than this one. And so right off the bat, I can see 3 different examples. This is sinus, well, not sinus rhythm, but this could be mistaken for sinus rhythm because you see, or sinus tachycardia, because you see a P before every QRS, and it seems to match our rules of positive here, negative here. But you need to pay attention that it's a different P wave before every QRS complex, and that's because we're having different foci sending the electrical signal from the atria down to contract the ventricles, and that's causing tachycardia because you're having multiple different signals. Next, let's take a look at this one. 3, 2, 1. This is a premature ventricular contraction. And so what I'm looking at here, everything looks good except you see here. You see this weird spike, you see this weird spike, you see this weird spike. And so everything looks like it's going fine and normal until suddenly you just have, boom, a big spike. And so that's kind of how you need to identify it. And some EKG stuff is going to just be pattern recognition, but some of it you should be able to understand and explain. And so we have a strong ventricular contraction here, but it's premature because normally we should have this long distance, but right after our T wave here, so it would be there, we have boom, ventricular spike, and then we need to repolarize and recuperate until we get back into sinus rhythm. And so PVCs, you want to look for this boom, big spike. Take a look at this one. 3, 2, 1. This is ventricular tachycardia, and that can be monomorphic or polymorphic. And so with ventricular tachycardia, or VTAC, you're just going to see tachycardia of the ventricles. So you just see spike, 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 spike. And so you can recognize it by like this spike here, boom, boom, or like the negative spike here. But this is one you need to recognize this pattern because it's common and it's tested a lot. It's monomorphic because this looks the same every single time, pretty much. And so that's a VTAC monomorphic. How about this one? 3, 2, 1. This is also VTAC, but this one is polymorphic. And so you can see, let's look here at a rhythm strip. These don't quite look the same. Some of them are a little variable, different shapes a little bit, different like sizes. And so this is still giving us that boom, spike, 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 spike. Our ventricle, it's a ventricular rhythm for sure, but this is polymorphic VTAC. How about this one? 3, 2, 1. This is ventricular fibrillation, or VFib. And so the way this one will typically get described is just like totally everything's irregular. Like there's no discernible waves or no P waves, no QRS complexes, nothing. You just see a bunch of random squiggles. It is still squiggling, so it's not asystole, which is just a flat line, but you just have this random squiggles with no discernible waves. And so next, let's look at this one. And this one, this is over time. So it starts out with this, and then it progresses into this, and then it turns into this final one here. So what would that be? 3, 2, 1. This is called torsades de pointe. And so you might get a little confused and say, well, hey, that looks like VFib. I don't see any waves, or maybe even VTAC, where we just see spike, spike, spike. But this is typically going to result from QT prolongation. So your QT interval will get longer and longer and longer until you start to get torsades, which is extremely dangerous. And you have this kind of wavy pattern, up and down and up and down. And so torsades in French, this is something like twisting. So it looks like you're kind of twisting, big, small, and that's important. That's why you need to manage QT prolongation. A lot of drugs can cause QT prolongation, and so if you start to detect that, you need to limit it so that you don't go into torsades. And so here's just a quick comparison of our ventricular rhythms. We have monomorphic VTAC, polymorphic VTAC, which is a bunch of big spikes but kind of just random, and then you have torsades, which you have this twisting pattern, up, down, up, down, up, down. 3, 2, 1. So this is a STEMI, which stands for a ST segment elevation myocardial infarction. So when you have a myocardial infarction, a heart attack, then your labs are going to go up, your troponin, maybe BNP, and so you're going to say, crap, we're having a heart attack. You look at the EKG, you can define it as STEMI, which is ST segment elevation, or NSTEMI, which is non-ST segment elevation, but you still have the labs indicating heart attack. And so if you have a STEMI, if you have a heart attack, you want to be able to localize where it is roughly. And also you need to know if you're having a heart attack, that's because you're having occlusion of a vessel. And so if you have ST elevation everywhere, then that wouldn't make sense that you simultaneously had an occlusion of every vessel. That would be unlikely. And so what you need to look at here, this is an inferior STEMI. So you look at everything, it looks fine. And then boom, in our inferior leads, 2, 3 AVF, you see this elevation in our ST segment. And so here's our baseline. This is clearly above 1 millimeter or 1 small box above that. And we see that in 2, 3 AVF. You don't see any elevation in any of the other leads, you'll notice. And so that's making me think, okay, maybe we have a STEMI in our inferior leads, which would be our right coronary artery most likely. What do you need to do to confirm this? You can't just say, I see a STEMI. You need to look for reciprocal depression. And so if the signal is causing this to go up, if we're having ischemia, then we should have an inversion in the opposite leads. And so that's up in our inferior leads. Oh, look at your lateral leads. That's depression. Not there so much. Maybe a little depression there, but you do see some reciprocal depression and ST elevation there. So that's an inferior STEMI. Typically, that's going to be right coronary artery, especially for examination purposes. 3, 2, 1. This is another STEMI in our anterior leads, and so that's likely going to be our left anterior descending. So you see this, everything looks fine, and then boom, V2, you have ST elevation, V3, ST elevation, ST elevation, not really ST elevation past here. And so we see anterior leads have some ST elevation. Do our reciprocal leads have depression? Let's look at our inferior ones. That looks like some depression to me. That looks like some, and it doesn't have to be incredibly drastic. You just need greater than 1 millimeter of change. And so this is an example of a STEMI in our LAD, or our anterior leads, likely LAD. Three, two, one. Here's another STEMI. You could probably guess, but this is going to be in our lateral leads. So if we look at it, where do we see ST elevation? Well, I see in lead 1, this is clearly higher from our baseline. So we have ST elevation in 1, ST elevation, AVL for lateral, and then a little bit in V6, maybe some V5. The ST segment's not quite elevated there, and so looks like our lateral leads, ST elevation. And then look at that, our anterior leads, we have some depression here, so reciprocal depression, and also in our inferior leads, depression. And so I would say this is a lateral STEMI, likely our left circumflex artery. And so here's a good summary slide just to keep it in mind. So we have our inferior leads, lateral leads, and anterior leads. And especially for the purpose of examinations like step 1 and step 2, you need to think of it from this point of view. They don't even have to show you the EKG. They can just say you see ST elevation in leads V1, V2, V3, and V4. What do you suspect it is? And you're going to say that's ST elevation, myocardial infarction of the left anterior descending artery. And so they don't even have to show you this. Just remember AVF, I think AV floor, that's inferior leads. AVL, I think AV lateral, that's your lateral leads. And then the V1 through V4, that's your anterior. So this is an excellent review slide, and it's important to understand the localization of the leads in regard to STEMIs. Take a look at this one. 3, 2, 1. This is a heart block, and this is a first-degree heart block. So this one can be pretty tricky to identify because you're not always looking for it. But if you go through the algorithm, one of the things you get to is your intervals, and you get to the PR interval. And so let's look at our rhythm strip down here. Our PR interval, well, looks like our P wave is here, and then our R doesn't occur to there. So that's easily over 1 box, maybe even 1.5 boxes. So that's greater than the 120 milliseconds that it has to be. And so we have a first degree heart block is going to be prolongation of the PR interval, and that's all it is. And so I'll do a review of the different heart blocks at the end of this in a second, but first degree heart block, prolongation of the PR interval. And just think of it as greater than 1 large box. 3, 2, 1. This is a second degree heart block. Within second degree, you have 2 types, Mobitz type 1 and Mobitz type 2. The Mobitz 1 heart block is also called a Wenckebach heart block. And so what that looks like is you have, okay, normal PR interval. Well, let's look at the rhythm strip. Normal PR interval looks like it's maybe a little longer, but still normal. A little longer, probably abnormal at this point. That's definitely prolonged. And then P wave, no QRS complex at all, so no heartbeat. And so what this is commonly described as is like going, gone. So you have a progressively enlarging PR interval until you suddenly drop a heartbeat. And then it starts over, small, longer, drop. And so that's what you want to look for. If you're counting the PR interval, you'll notice that it's small, getting longer, and drops. And so I've heard people say going, gone is Mobitz type 1. So that's what you want to look at for second degree heart block type 1. 3, 2, 1. So this is also a heart block. And so this is a second degree heart block, Mobitz type 2. And so what does that mean? Well, we look at our rhythm strip here. This is all lead 2. And we see, okay, our PR interval's fine, PR interval's fine, PR interval's fine. Oh, suddenly there's no QRS complex. And so what this one is you have normal, just like normal sinus rhythm, and then suddenly you drop a beat. And so normal, boom, suddenly you drop a beat. Normal. And that's in contrast to the second degree block type 1, where the PR interval prolong, then drops. Second degree type 2 is always normal, but just randomly, well, not randomly, always normal, but it just suddenly drops a beat. And so this one, you'll have like 3 and then 4. And so as you're progressing in degree of heart block, these are getting worse and worse and will likely be more symptomatic and demand more treatment. And so how about this one? 3, 2, 1. You might have been expecting a complete heart block, but that's not what this is. This is a 2-to-1 heart block. And so what can be tricky is if you have one normal rhythm and then a drop, and then one normal rhythm, and then a drop. You could say, well, I don't know, that's definitely second degree, but I don't know if that's Mobitz type 1 or Mobitz type 2, because you can't tell if the PR interval is prolonging because there's only one beat in between. And so that's what this is an example of. You have P, QRS, P, drop, P, QRS, P, drop. And so you don't know if this is Mobitz type 1 or Mobitz type 2. This is just a second degree heart block, 2-to-1 fixed intervals. Three, two, one. This is a third degree heart block, also known as a complete heart block. And so when thinking about this should conceptually make sense why it's happening. So a heart block is just prevention of signal from going through the AV node all the way. If you have a partial block, type 1, type 2, then if it's type 1, it's just slightly delayed, a longer PR interval. That's fine, probably not too bad. But some of the type 2 ones, it takes longer and longer, or you suddenly don't conduct at all. That's starting to get more severe. If you have a complete heart block, then the atrium and ventricles are not connecting at all. They're not talking at all. They're both independently firing without each other. And so how do you identify that? Well, if your atrium is contracting without getting feedback from your ventricles, and your ventricles are contracting without getting feedback from your atrium, then you should see the normal waves, the normal P wave from the atrium, normal QRS from your ventricles, but they should be independent of each other. And so commonly, you'll look at the P wave. The P waves do not have a QRS after each one of them, and the QRS does not have a P wave before each of them. So this one, it could look like it. This one doesn't really have it. This one kind of. But when you look at the P waves, they're going to be evenly spaced out and independent. So P wave, P wave, P wave, P wave, P wave, P wave, P wave. And so you'll see this going all the way across, equidistant, regular intervals, P waves just contracting on its own. The atrium are just doing their own thing without any concern for the ventricles. And so that can also be tricky. Don't get confused that sometimes it'll overlap with another, like with a QRS complex or with a T wave. And so you might just think, well, these are spaced further apart. But no, you can actually kind of see, here's one, it's just under the T wave. Or if it's under the QRS complex, you might get confused and think it's something else like Wolff, Parkinson, White, but you need to look at the whole picture. And so we now look at our QRS complexes. Those are happening just regularly, independently, without a P wave before it every time. And so you see them acting independently of each other because there's a complete block at the AV node between the atrium and ventricles. And so here's a summary slide of that. First degree, you just have a prolonged PR interval. Second degree, type 1, is it's going, 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 gone. Longer, 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 drop, PR interval. And why is it the PR interval? Think about it. That's because the PR interval is the delay from your SA node firing, your atrial contraction, delayed in the AV node to contracting the ventricles. And so a longer delay is more of a block in your AV node. So these are AV blocks. And so going, going, gone, Mobitz type 1. Mobitz type 2, normal PR interval, suddenly no contraction after the P wave. Normal, normal, normal. And so you just see normal PR, but a random drop or a sudden drop. And then you have your 2-to-1 block, which can't really technically be placed into either one of these. We see PR and then drop after P wave. P contraction, P drop, P contraction, P drop. And then finally you have your complete or third degree heart block where the P waves are just independently and regularly spaced, and the R waves are also independently and regularly spaced. So no P before every QRS. 3, 2, 1. This is an example of left ventricular hypertrophy, and I'm saying that because this has high voltage. And so how did I say to look at high voltage? Well, let's look at this spike in V2 and this spike in V5. And you can honestly just eyeball it, but it needs to be greater than 35, which is greater than 7 big boxes. So 5, 10, 15, 20, 25, 30, 35, 40. So this alone is greater than 35. So if you add this plus this, that's severe left ventricular hypertrophy or severely high voltage. Three, two, one. So what is this? This is a left bundle branch block. Why am I saying that? So a bundle branch block is going to delay or prolong the conduction pathway. And so how do you know to look for that? Anytime you see prolongation of the QRS complex, what is that saying? That's saying that your ventricular depolarization, your ventricular contraction is slowed down, it's spread out. And that's because you have a block in your bundle branch. And so if you see QRS prolongation, I want you to look at lead V1. And so if you have QRS prolongation and lead V1 is negative, down, that's a left bundle branch block. If you have prolonged QRS and V1 is positive, your QRS is positive, then that's going to be a right bundle branch block. I remember that by thinking upright, like the term upright, something is sitting upright. So if it's upright, then it is up and right bundle branch block. And so this is an example of prolonged QRS by a left bundle branch block. 3, 2, 1. This is an example of a right bundle branch block. So we look at this, we see a prolonged QRS interval. So let's look at V1. V1 is upright, it's right, so we have a right bundle branch block. Three, 2, 1. This is an example of hyperkalemia. And so electrolyte imbalances can often disturb the heart, especially with potassium, and that can be shown in the EKG. And so examinations will typically only test potassium, so that's all I'm showing here, but hyperkalemia, what do you want to look for? You want to look for spiked T waves. So you have a lot of potassium, you're going to have a really big T wave. And that's the main thing that I look for. I'll show a summary slide with a couple extra changes, but you have these spiked T waves. And so what happens over time, this is your normal complex. As the potassium starts to get higher and higher, so I'm talking normal is 3.5 to 4.5 as you hit 6, maybe here, 8, maybe here, 9, maybe here, 11, you get that. And so your T waves start to spike. And then you start to get this prolonged PR interval and widened QRS. And then you start to get even more exaggeration of that. And then suddenly it becomes fibrillation. And so this is the progression as your potassium gets higher and higher and higher. And that's why we need to tightly regulate potassium, because it has major effects on the heart and you don't want to get ventricular fibrillation. So the main thing you want to look at for hyperkalemia is spiked T waves. 3, 2, 1. This is hypokalemia. And so what I'm looking at here, I have a summary slide here, but with low potassium, so here's high potassium, we talked about that. With low potassium, hypokalemia, you'll start to see flattened T waves, which is repolarization of the ventricles. So too much potassium affects repolarization, too little potassium affects repolarization. And then you're going to start to see this U wave become a lot bigger, and it'll get even bigger with the more you have. And so if we go back and look at this, I know this is a little blurry, but if we just look like somewhere you can see, I don't really see much of a T wave. I mean, maybe it's kind of hidden in there, but it's certainly flat. Like here, maybe you can see really flat T wave, and then you suddenly see this U wave there. And so that's your indication that you have low potassium hypokalemia. 3, 2, 1. This is an example of Wolff-Parkinson-White, which is a certain syndrome where you have an aberrant electrical pathway conducting down into the ventricles. And so that can be located in many different locations in the heart. But basically what that means is your electrical signal is not just going through the AV node down into your bundle branches and all that. It has a separate pathway that it's going through. And so if you think about that, what's that going to mean? Well, the electrical firing of the ventricles and contraction, the depolarization, is demonstrated by the QRS complex. And so if we have this extra signal, this beginning of depolarization and contraction of the ventricles on their own, despite the normal pathway, we're going to get a certain widened part of our QRS complex. And you can see that here with this slight upstroke. So let me go to here. That's called a delta wave. And so normally a QRS complex is very sharp up and down. But if you have this delta wave, that's the extra electrical pathway firing on its own before the actual normal pathway spikes. And so what you want to look for with that is this delta wave here, and then a basically non-existent or a very short PR interval, because the normal PR interval is eliminated because you have this delta wave overlapping it. And so you basically have a P wave straight into a slower sloped delta wave into the QRS complex. So let's go back. You can see this here. You have, it's hard to see the P wave here, maybe here. There's a small P wave and then straight into this upward slope and then into your spike. And so you can see that in different leads. So you need to check every lead as always, because it's not always going to be in one particular lead because it can be in different locations. And so if I just looked here, I don't know that I would actually say there's a delta wave there. I don't know that I would pick up Wolf, Parkinson, White. But if you look over here, in some of these, it's a lot more obvious, like right here. And so that's Wolf, Parkinson, White. 3, 2, 1. This is an example of electrical alternans of your R waves. And so this is indicative of pericardial effusion. And so what am I looking at here? The key thing you want to look at here is the height, the voltage of your QRS complex. It's going to alter. So it's going to go up, down, high, low, high, low. And so you see this pattern of your QRS complexes being higher, lower, higher, lower, higher, lower. And that's indicative of an effusion in the pericardial space, kind of compressing the heart. And you can see that on an echo. And so let's look at this one now. And you can ignore the arrows. This is not all that I'm trying to show here. Okay, this is a really tricky one, but it's very important to understand. This is an example of cardiac tamponade, which is bleeding or effusion or something into the pericardial space that has constricted the heart so much that you're now starting to see like major changes. And so what I'm looking at here, the main things I want to look at are ST elevation. So some of you might have said, well, is that a heart attack? I see the ST elevation here. Looks like ST elevation there. Well, it looks like ST elevation in basically every lead. And so this is diffuse ST segment elevation. And so that's one indicator. Another indicator is inversion or negativity of the PR interval. And so you can see here the PR interval is downward. It's kind of negative here. And that's also should be like fairly diffuse. You can see down here. And so when we're looking at, this is acute pericarditis, but cardiac tamponade, the main things you want to look at, you have diffuse PR depression. You have widespread concave ST elevation. So that's the main two things I consider. I look at ST elevation in multiple leads without the reciprocal depression, and I look for PR depression in most leads. The only exception here is you can have reciprocal depression in AVR, which you might have noticed here. There is the depression right there, but otherwise we have diffuse. And so this is like I'm saying before, it's unlikely, highly unlikely that you're going to have a ischemic cardiac event in every major vessel at the same time. And so that's likely indicative of cardiac tamponade. And this one gets tested on a lot, so I would certainly know it. 3, 2, 1. This is also a very tricky one. This one is probably the hardest to pick up on, but this is referred to as a S1Q3T3. And this is typically indicative of an acute major pulmonary embolus, like a saddle embolus might cause this. And so it doesn't have to cause this, so it can still be a PE if you do not see this, but this can be a good indicator of that. And so what does that mean? So it's talking about the S wave in lead 1, the Q wave in lead 3, and the T wave in lead 3. And so let's look at lead 1. We have our S wave, so we think QRS. So the S wave is really big here. And then we go to lead 3, Q, so QRS, so our Q wave is really big there. And then T3, our T wave in lead 3 is going to be inverted. It's negative. So I see S1 is big, Q3 is big, and then inverted T wave. And so S1, Q3, T3. Okay, here's another tricky one. These two are going to be more important for when you're in the hospital working and not so much as important for examinations like STEP. But you might look at this and you say, this looks like terrible. We see widened QRS, we see all sorts of stuff. But the key things that you need to notice here is this, boom, really thin, narrow spike right before our QRS complexes. What is that? That's a pacemaker. So the pacemaker is sending the spike signal to activate the QRS. And so this is a totally normal heart acting in response to the pacemaker, signaling it here. And so this is what a biventricular pacemaker looks like going into both ventricles. 3, 2, 1. This one is also a pacemaker. You probably picked up this extremely narrow, like one line spike right before every system. And this is a atrial pacemaker. And so you can see spike, and then we have P wave, QRS. Spike, P wave, QRS. And so those are just the two pacemaker leads. Just so you don't get confused in clinical rotations, if you see that, it's being paced. And so this is not like a major arrhythmia, it's just being paced by the pacemaker.